Good afternoon, everyone, and thank you so much for being with us for the University of Kentucky's Behavioral Health Community of Practice. We are delighted to have you with us, and we have such an important topic to talk about today during this community of practice. So today we're going to be talking about responding to mental health crises in primary care. And I am sure that if we went around and told stories of patients that our organizations have had to deal with in crisis, that, this would take a lot longer than an hour. And when I think about this topic today, I think it is so critical. First of all, we want to be ready for our patients to give them the very best when they are in such severe need of our help. But we also want to help, we also want to be ready for these crises that occur because we want to be able to help our staff. We know that these type of crises that just happen out of the blue in primary care offices and community mental health centers, and the increase in the number of patients that are in crisis has been so precipitous since the pandemic. It's incredibly stressful on our teams, and there's a lot of moral distress that comes along with it. Having a good plan can really help with making sure that these types of situations are handled to the very best of our ability. So today we've tried to put together what is a highly informative and also interactive session with you all to help equip you, to help your patients and your teams to manage well during times of crisis. We have a great panel of speakers too. Before we get started though, we do want to hear from you and get a little bit a sense of where your organizations are. So I'm going to pass it over to Katie to talk about our Mentimeter today.
Sure. Hi, everybody, and thank you so much for joining. We've posed just 2 questions for the audience to kick us off today. The first of which is, do you implement safety planning with your patients? And the way that you will answer this question is either through scanning the QR code in the upper right-hand side of the screen, or clicking the link that I just dropped into the chat. That will bring you to our Mentimeter activity where you can vote. Yes, I do implement safety planning. No, I don't. There are a couple of different options. I'm going to go ahead and stop sharing and then get that activity up for us on the screen. Thank you.
While we're waiting for those results, I want to go ahead and introduce one of our first speakers, and we'll transition after the Mentimeter activity to that. Lindsay Jasinski is going to be our first speaker today. She's Chief Administrative Officer at Eastern State Hospital. She's a clinical psychologist and has been with UK Healthcare since 2010 in various leadership roles in the Department of Psychiatry and also at Eastern State Hospital. I also consider Lindsay a friend. She's a lovely person who does great work here at UK Healthcare on behalf of our patients with behavioral health needs. So she'll be kicking us off today in terms of our sharing. Okay. Katie, looks like we have some responses already. Do you want to share, Katie? So first of all, the first is yes, all of the time. So it looks like we have some folks, and then there's several folks who don't provide direct patient care. So it looks like some additional responses are coming in. Most of the time, only sometimes. Good to get that background from folks.
Absolutely.
Yeah, that's interesting, Trudy, because it's spread pretty evenly across folks, that there's kind of a wide variety of implementations, which is consistent with what the literature shows as well.
And then we do have one more question for folks today, and that is, does your organization have a mental health crisis response plan? So you should be able to go ahead and advance the activity on your device, or click that link one more time and participate in this question as well.
I'd like to see at least half of our folks participate so that we could get some good data to help us understand where folks are at and how we can support.
And Lindsay, for context here, the responses are yes, no, and I'm not sure.
Looking like a good number do, which is promising. That's exciting. for those folks saying, I'm not sure, I think it would be good to go back and check with your organization and see, what is your mental health crisis response plan? And I will caveat too, I think it's important for us at this point in time to think about a mental health crisis response plan, not only for the patients and the folks that we see from the community, but our own staff, and understanding, are there resources that we have available for our staff who may be experiencing mental health concerns or even a crisis in the workplace.
Okay, thank you all for your participation. I will go ahead and share the slides again.
Well, Trudy, your introduction was very kind. I also am very fond of Trudy. She's a wonderful advocate, a wonderful person, and we feel very fortunate to be able to work with Trudy and her team through this community of practice to share some knowledge and hopefully advance the practice of our providers in the community as well. So we are going to be talking, and Mark Woods was able to join us. He's our Chief Nursing Officer. I'll tag him in if I need to as well. We're kind of managing multiple priorities today, so I had agreed to take on this one. So I'm going to talk about safety planning, and safety planning is a really important piece. A few months ago, many of you might have attended with us where we talked about doing a good foundational risk assessment in your practice, and that's a Joint Commission requirement. But in addition, the other Joint Commission part of this as a national patient safety goal is to ensure that you have a documented risk mitigation plan for each individual who does screen positive for some sort of mental health crisis or suicidal ideation. I do want to give a shout out to my two colleagues, Dr. Sean Riley and Dr. Terry Maynard, who are psychologists here at the hospital, who have done a lot of work around this topic and have given similar presentations in the past as well. So you can go ahead. And very quickly, my objectives is I'm going to go through some safety planning, high level basics, and then provide kind of an overview of one particular safety plan that is evidence-based that's often used. You can go ahead and advance. So first of all, defining a crisis. This is my colleague, Dr. Riley, and probably many of us have felt like this at times. But a crisis at a high level is something that is highly stressful, and in fact defined as something that overwhelms someone's ability to cope. And so our baseline ability to cope differs in different situations. But what we know is this overwhelms our ability to cope. It is short term. And what we know is that individuals in crisis who receive services go on to continue in the community most times. And that is the goal, is to keep folks in their home, in their roles, and not disrupt them by utilizing a hospital situation. And in these crisis situations, it creates intense pressure to act to resolve that crisis, both from the patient that you're seeing and from the staff member. But what we know is that in that crisis situation, if your ability to cope is overwhelmed, using kind of a standard operating protocol as a safety plan or a coping plan is the best way. If I'm in crisis and I'm having trouble thinking, what do I do in this situation? And I have my coping plan. It might be in my phone, it might be on a piece of paper, it might be in an app. If I have that available, all I have to do is think, let me pull that up, and it's ready for me. I'm not having to think about, oh, what should I do to cope, or who should I contact? Go ahead. So I really like this quote regarding safety planning to kind of set the foundation, to put the part of you that wants to live in charge. It's helpful to plan how you'll get through those difficult moments. And that's really what safety planning is about. You can go ahead. When we look at what is safety planning, it's really a collaborative intervention, right? It is not just filling out a piece of paper. It really is a collaborative discussion to lower that imminent risk. It follows a comprehensive assessment. So you don't want to be safety planning if you haven't done a good risk assessment first. This is the second step. It's used in lots of different ways in lots of different settings. It can be used in outpatient settings. It can be used in the ER. It can be used in an inpatient hospital. It can be used by a crisis response member in the community. But the idea overall is that you're getting a personalized safety plan. And there was a study in 2016 by the VA that showed that a safety plan really is not effective unless it is individualized. It is personalized, that individual's resources, their community, their supports. Go ahead. So I want to make a really important point, and that is safety planning is not a no harm contract. And so this was, 20 years ago, what we used to do is talk about creating a no harm contract, which if someone came into me, I would say to them, okay, I'm going to have you sign this piece of paper that says you are not going to kill yourself until you see me again. What we know is that there is very little evidence base for that as an effective intervention. What we do know is that a safety plan is actually an evidence-based risk reduction strategy that is a collaborative process. It's a discussion. It is a development of a coping plan and a crisis response plan. It is recovery oriented. The primary goal of that plan is to instill hope by offering options for coping. When someone gets to the point of considering suicide, they're considering that because that is a way to solve their problem. The problem is intense, overwhelmed distress that they don't have another option to solve. And what you're doing is you're increasing their available options to help solve that problem and cope with that crisis. So it's a tailored, individualized plan. Go ahead. That can be done in a multitude of ways. I listed these because I want you to see a couple of options. I want to focus on the safety planning intervention, which is the Stanley-Brown. Go ahead. And CAMS is another great model. I could give a whole talk on CAMS. It's a really, really great evidence-based intervention, but I'm going to talk about the Stanley-Brown safety planning intervention as identified as the SPRC, the Suicide Prevention Resource Center, as a best practice. You can go ahead. So this is kind of the overview of safety planning intervention, and it's really designed to be brief, like a 20-minute in-clinic collaborative discussion. Can be done by anyone, can be done by a physician, an advanced practice provider, a psychologist, social worker, a nurse can do these. It's typically done in a variety of settings, and it complements that risk assessment. So you can see left to right on the bottom, what you're really doing is identifying that risk, and then you're obtaining that crisis narrative. What's going on? Then you're introducing that safety plan, and you're describing a risk curve going all the way through to follow up at the end. I'm going to talk most specifically about that crisis, that safety planning and the crisis narrative. Those are really important foundational pieces of this. You can go ahead. I'm not going to have time to talk a lot about the evidence base of this. However, what we know is that people who receive an intervention in response to a mental health crisis, or specifically suicidal crisis, are 50% less likely to attempt suicide if they receive some sort of intervention. That is huge. Many of our medications don't have that level of impact, and we know this can be really effective. So I want to stress that point, that this can work, and this can actually reduce the risk of someone going on to attempt suicide. Go ahead. So again, that assessment, I'm going to highlight that. You can have access to these slides, gladly share them. These are different options for assessing risk, but the Columbia is the one that we use at UK Healthcare pretty extensively. I know lots of other organizations do as well. That's that third one listed there. Go ahead. So when you're looking at that assessment, you've assessed someone, they have increased risk, you've identified they have some suicidal ideation. What you need to know next is what's going on. They may or may not need an emergency room visit. They may or may not need hospitalization at that point. And so through safety planning, we're going to pull that out a little bit. That crisis narrative is really the context and the foundation. You, as the person talking with them, have the ability to then pull that in to pieces of the safety plan. It tells the story, what has happened that has led them to feel hopeless and so overwhelmed. And you're kind of starting this story backwards from where we are today. Take me back and help me understand what's happening. What are the triggering thoughts? What are the feelings, the sensations, and what are the decision points that lead us to believe that suicide is the best potential or a potential out? Go ahead. So when you're introducing safety planning, what you're talking about is some short and long-term goals. So it's having a crisis plan ready. And you're saying, hey, you know what? If I need to have a backup babysitter, I'm going to have my list of options, right? It's the same thing here. If I get into a situation where I'm experiencing suicidal thoughts, I need to have my options. I need to know what's happening. And so it's these short term, immediately reduce that distress. And these long term, how am I going to cope and use my support system? Go ahead. So the components here of the actual safety plan are warning signs, those coping skills, distracting, either with people or social settings, and then going through to who else do you contact? And that's, my colleagues are going to talk about that a little bit more extensively. And then that lethal means restriction. Go ahead. So when you're looking at warning signs on each of these slides, I've added questions about how you might ask these questions. So how will you know when you need to use this? What do you experience when you know you're in crisis? How do you feel when you're depressed? You can go ahead. And then when you talk through those with the person, you're then going to say, okay, so how can you cope with that? What do you have that helps you feel differently? What activities could you do to take your mind off this for a little bit? What can you do if you feel like you want to act on this? What are your coping skills? You can go ahead. And then how would you be able to use those skills during a crisis? So you want to also identify barriers. What if I don't have my coping skills with me? What if I'm at work and I don't have the ability to step away? How would I cope in that particular situation? Go ahead. And then using the people around you. So people are used differently. People are used as support. I might be willing to go to someone I'm close to and say, I am feeling suicidal, but I might not be willing to tell them that. I might just say, hey, could we go out and go for a walk, and maybe not share the level of detail with them. And so you want to talk through with them, who would you talk to and what would you talk to them about, and how can they support you? Go ahead. And this is exactly that. Who would you contact if you needed to share this information or ask them to help you get support? Or who would you contact to be willing to say, yeah, I'm really in crisis here? Go ahead. And then who would you contact in the community? I'm not going to belabor this because my colleagues are going to talk more about this, but we need to have a plan for who are my resources in the community. Go ahead. And then lethal means restrictions. And this is really important. And you actually document this, I'll show in a second, on the safety plan. Do they have access to a firearm? You really want to talk about that, and how do you work with the family? That is in Kentucky something that's really important. I don't have time to go into tons of detail about it, but you do want to assess, what are you thinking about doing to harm yourself, and how can we lock up your medications or reduce access to weapons or things like that? Go ahead. And then the last part of this that I think is really, really important is, who or what do you have to live for? And this is a really powerful question for instilling hope in folks and helping them understand, what is my meaning? What is my purpose? What is important to me that I can identify as a protective factor? Go ahead. So in the last minute or two, I just want to run through, and again, I'm happy to share these slides, what this looks like. This safety plan, the Stanley-Brown safety plan, is widely available online. It's easily accessible. And in fact, some EHRs are actually have it built in. So you could look in your EHR that you use to understand whether or not this is already available to you. You can go ahead. Each section is broken down into the warning signs. So you can see those written out there. You want to identify at least 3 thoughts, mood, behavior, situations that are warning signs. Go ahead. And then you have those internal coping strategies that I've talked about. Go ahead. And those people and their contact information. So I don't have to go through the effort to look them up, to find their phone number. They're readily available. Go ahead. And then individuals who I can actually ask for help, to say, I'm in crisis, I'm needing support here. Go ahead. Actually, as a side note, I have a lot of my folks create a list in their phone of contacts and just put them in their quick contacts so that they can quickly call them and easily get a hold of them. And then I'm going to turn it over in just a minute to my colleagues who are going to talk about this, but this is where you want to identify your local resources. This is a bit of an outdated form. 988 is now the number to call, and I know Darcy's going to share that at the bottom. Go ahead. And then talking about means restriction and environmental safety at the end. Go ahead. And at the very end here is the reasons for living, and this is really important to make sure that you have something on there. And the last slide, I believe, for me is where to find more about the safety plan, some additional resources on how to do this. This is something that can be a really powerful 20-minute intervention. I'm happy to answer questions at the end. I want to make sure to give my colleagues time, but this is something at a high level that can be used really easily and really effectively in any practice. All right, Trudy.
Thank you so much, Lindsay. That was a lot of material to cover in a very short period of time. So we are so grateful. And yes, please do drop questions into the chat. Lindsay can respond to those while the other speakers are talking. And also, we can come back to them during the panel section. So I want to transition over to Darcy. Thank you, Darcy, for being with us. Darcy Miller received her MA in counseling from Asbury Theological Seminary, and she works for New Vista. And in that role, she does a lot of things, but she also provides training for mental health professionals on assessing and managing suicide risk. And she's the regional director of emergency response and client engagement for New Vista. So she has a lot of expertise to offer about how to work with the community mental health centers and others if you have a patient that's in crisis. So Darcy, take it away. Thank you so much for being with us.
Hi, everybody. I'm glad to be here. Yes, I have been a licensed counselor for 23 years and have worked with New Vista for 23 years. So and I think I've worked specifically for emergency work for 15 years, just crisis work. I'll go ahead into the next slide. So what I wanted to talk about today is what the involuntary process looks like. So if you feel like you need to petition someone because you feel like they need to go to Eastern State Hospital or a psych hospital and they're unwilling, but you're worried about their safety. The other is, what are the alternatives to hospitalization? The community mental health centers is kind of the stopgap. It's the safety net, so we can avoid hospitalization if at all possible. And then what to do for tips and tricks for positive interaction when someone is struggling with a behavioral health crisis. Next slide. And just to give, we're not going to spend a lot of time here, but just to give some data for you to refer to later, we can send out slides or what have you about suicide, death by suicide in the United States. We try to avoid, we're changing the language of committed suicide. They committed suicide because when you hear the term committed, it's like when you think of that, like someone committed a crime, and suicide isn't a crime. It is when someone's having suicidal thoughts, it's a symptom of someone having a crisis. So it's death by suicide. But it is the third leading cause of death in our nation from ages 10 to 19 and second for ages 20 to 34. I did find it interesting that over 1/3 of people who died by suicide were 55 and older. And there's lots of, you can look up more, especially at the National Foundation of Suicide Prevention. It can give you some of the reasons for that. End of life can be pretty tricky at times. People feel really lonely and isolated. Next slide. And then we tend to mirror the rest of the country. It is the second leading cause of death for ages 10 to 24, the first leading cause being accident. I will say we have maintained our rate since 2020, but we have actually reduced it. We are lower in cause of death in this past rating than we were previously. So that's good. Our rate has changed, but other parts of the country are struggling with suicide more than we are in our state at this point. Next slide. So talking about the involuntary evaluation process. So if you petition one of your patients for an involuntary evaluation, The local community mental health center, we're the gatekeepers, and we are the ones that provide that evaluation. And to do a petition, the patient has to meet two criteria. One, they have to have a mental illness, or their crisis is due to a mental health issue. And the second one is that they present a danger to themselves or others, their family, due to that mental health issue. This could be suicide, but this could also be due to some type of psychosis because of schizophrenia, bipolar disorder, being manic and not being real safe. I've seen people that we've evaluated and admitted because they have a delusion that water is going to harm them in some way, that there are microbes in there. The CIA has put something in there because the government is trying to control them, and they stop drinking all fluids. Well, if you stop drinking all fluids for long enough, you're at risk for dying. So that is another, it's not just suicide. There are other ways that you can be a danger to yourselves or others because of serious mental illness. All of the criteria to be admitted to the hospital, and this is involuntary. This is someone going to be admitted to Eastern State Hospital or another state psychiatric hospital against their will, is, like I said, they have to have the first two, but they also have to reasonably benefit from treatment. And it has to be the least restrictive mode of treatment. So, for instance, if someone is having psychosis because of substance use, it's not due to mental illness, and they're not going to benefit from treatment from a psychiatric hospital. That doesn't mean that they don't need treatment. That's just not the place that they need to be. They may need to detox and be put in a rehab or some type of substance use. So all those criteria have to be met. And when we say least restrictive mode of treatment, they could meet all of the first three criteria, but they could be willing to go to the hospital. And if they're willing to go voluntarily to a hospital, I would encourage other alternatives, and I'm thinking of in the central Kentucky region, or even out towards Louisville, like Our Lady of Peace, Bourbon Hospital, Ridge Behavioral Health. If you're voluntarily able to go, that's considered a less restrictive mode of treatment because you're not being held against your will. Next slide. So we also talked about trying to avoid hospitalization and what are the alternatives. And this is where the Community Mental Health Center comes in. And New Vista is one of the community mental health centers. And we offer most of these, and I'm including some others because I know not everybody is from the Central Kentucky region that may be here. So we have our 1-800-928, oh, there's a typo. That should have been 928-8000. So before those last 3 zeros, there should be an 8. And that's our helpline. You can also call 988. And that is answered locally. So it is based on area code. I think the only tricky thing about that is if you have, like I'm thinking of my mother who is from Pennsylvania and moved down here to be closer to us. She kept her Pennsylvania number. So if she were to call 988, someone in Pennsylvania would answer, but they would route it to Kentucky very quickly. We also have a mobile crisis team that operates 24/7. We have something called our critical evaluation team. That's the team that does those involuntary evaluations. They also help our helpline on call if we need to speak to a therapist on call. All community mental health centers have outpatient walk-in emergency. So you can go to your local community mental health center outpatient and say, I'm in crisis, I need help. Some parts of the state, some community mental health centers have crisis stabilization units. And that's a CSU. Again, it's that in between. You need a little bit more than an outpatient, but you don't necessarily need to be admitted to a psychiatric hospital. You need something kind of in between. Those are usually voluntary. And I sent a list that I think Katie is going to put on the resource page, all the CSUs in the state. And it doesn't have to, you may be from a neighboring county. It doesn't have to be a CSU in your county. You just like hospital systems, you can refer outside your county. And then here at New Vista, our future planning, hopefully this year, that we are going to offer a behavioral health urgent care, which is going to be extended hours. We're looking, once we're staffed up, between like 10 a.m. and 8 p.m. Weekdays, and we're going to see what the need is. And I do know that some of the options that are being developed here in the state, Louisville had this for a brief time. There were some issues with funding, but in our country, we're looking at the 23-hour bed. Because if you look at mental health crises, sometimes you just need just a break. You don't need to be admitted to a hospital or a CSU. You just need a minute to de-escalate and have the supports there. Next slide. So here's a map of our community mental health centers and our state psychiatric hospitals and where they're at, where they're located. I know that this is kind of hard to see, so I included a link in this slide. You can get to that and adjust, and there's also lots of resources with the Department of Behavioral Health about our community mental health centers and our intellectual and developmental disabilities resources. Next slide. So just to kind of piggyback a little bit on what Lindsay talked about with safety planning, I just wanted to talk about like what we really focus on in the crisis is the first 24 hours. Who's going to supervise? What are the coping skills? Means restriction, which gets into the firearms, or if they're looking at overdosing, medication management, things like that. When to check in and who to contact, and writing all of those things down. The number one way to prevent suicide is means restriction. And I've also found that if you tell someone you're looking at, well, how can we keep you safe for 24 hours? And then we can check in. That seems to be very powerful. Or asking the question of, when are you most vulnerable? When do these thoughts or feelings come to you? And they could be early in the morning, 8 o'clock at night, or right when I'm about to go to bed, that kind of thing. Asking those questions and how to create safety planning. Next slide. And positive interactions. One, validate their thoughts and feelings. Even though you may have a different perspective of what's happening or their reality is altered, what they are experiencing is real. That person who is having thoughts of that their water is contaminated, even though we know it may not be true, it's real to them. Be patient, create time and space. It is gonna take, this may take a little bit extra time than your usual patient. And also do one thing at a time, say one thing at a time so they can process that. Next slide. And then here's just some active listening skills about paraphrasing, reflecting, open-ended questions, doing minimal encouragers, also your body language, things like that. Go ahead, next slide. And here's some examples of how I talk about how to be the feelings translator, right? When they say things like, nobody in this place understands me, nobody is listening, you're not listening to me. How do you take that instead of going, yes, I am, and coming across as defensive of, so this is what you're feeling. You feel like you're not being heard. You're feeling like we're not helping the way you want. Let's kind of regroup and figure out how we can meet you where you're at. Next slide. Here's some common myths. Basically, just because someone's suicidal doesn't necessarily mean that they need to go to the hospital. Just because they're at the hospital doesn't necessarily mean we can force medication. And let's see. And asking about suicide is not going to trigger them to be suicidal. One of the powerful things that I want to share is if they're coming to you in crisis, even though that can be anxiety producing, they're in front of you, and that means you can help and you can reach out to people who can support you. Next slide. And this is just how to contact us. These are the counties that we cover at New Vista. And then I also, next slide. I want to talk about our My Strengths app. That's free to everybody, and it has the code See the Good. And I also wanted to share, Lindsay talked about Stanley-Brown, which is wonderful. They also have an app for safety planning too. So use your electronic devices and your patient's electronic devices if they have them. It can be powerful tools. Thanks.
That's fantastic. Thank you so much, Darcy. That's excellent. And certainly for those of you who are listening and participating today, if you have questions for Darcy, please do put those in the chat. We're going to transition in the interest of time over to Angela Roberts, who's the 988 Program Administrator with the Division of Mental Health Promotion, Prevention and Preparedness at the BHDID. And Angela is going to be here to talk with us about how to leverage the new 988 capabilities with your patients. Angela, thank you so much for being with us.
Well, thank you so much for allowing me to come and talk. So as she said, my name is Angela Roberts. I've been in the position of 988 Program Administrator for a year and have had the privilege of working with all of our community mental health centers, including Darcy and her team at New Vista. So next slide, please. So 988 is nothing really new. The concept of it is not new. And I'm sure everyone is familiar with the National Suicide Prevention Lifeline of the 1-800-273-TALK. That began in 2004, and over time, it has actually evolved to where it is now of more than 200 crisis centers across the U.S. And the thing about it is that it is a 24-hour, 7-day-a-week, confidential and free service available to anyone in crisis. Now, I said that the concept of 988 is not new. What is new is the way that 988 is being presented. So when we were preparing for this, we were working on, as a state, to have all of our community mental health centers that already had crisis lines for their local areas become part of the NSPL network, or the National Suicide Prevention Lifeline, and then make that transition over to 988. So the work has begun several years ago, around 2018 when this started. So next slide. So this is how Kentucky is structured. And we do have 14 community mental health centers, but of those, we have 12 primary centers that cover all 120 counties. So the ones that are shaded green are the ones that for which we have 988 centers located within the community mental health centers. The ones that are green and white striped are centers that have coordinated with another center to take on their calls. So again, all 120 counties are covered. Next slide. Where we're working to build capacity is that we're at about 88% coverage for backup of all of our counties. So pretty much everything in blue is covered by a backup center in Western Kentucky, which is Pennyroyal. And we're continuing to build capacity for the other 6 counties outside of Pennyroyal's area by working with our community mental health centers to build that, so that we can ensure that, as Darcy was saying, that the calls are routed by area code and prefix, that they stay in Kentucky. And our goal is to ultimately get to 90% answer rate with that. So we're continuing to build this capacity as we're now 7 months post launch of 988. So continue to do the work. Next slide. So as I said, 988 is not a new idea, but the concept of it is, and it really started in 2008. And these are just the different laws and the acts and laws that were enacted to get us to where we are now. What 988 really is a change in the crisis continuum, where it was before the National Suicide Prevention Lifeline for those experiencing a suicidal ideation. It has evolved to where it is now, where it's the 988 Crisis and Suicide Lifeline. So it's expanded out. It's gone from becoming a line for someone, first person experiencing suicidal ideation, to someone who's having a mental health crisis, whether they're experiencing anxiety or depression, or there's some other issue that they may have. But it's also expanded out so that it can be a third person calling. So we have evolved to that. And this is just the first step of it. 988 is not our ending point. It is the launching pad for where we're wanting to go with the continuum of care. So next slide, please. So we're continuing to evolve with this. And as we said, 988 is part of a 3-phase approach to this. And the ultimate goal across the country is that we have someone to call, which we have with 988. Then we have someone to respond, and that's going to be our mobile crisis piece. And then the third piece is a safe place to go, whether that is the crisis stabilization units or an inpatient facility or any number of different avenues to meet the needs of the individual that's in crisis. So as we continue to move forward with 988 in this continuum, we're looking at our success in that. Are we able to connect individuals experiencing a crisis to the trained counselors, or for that more advanced care that they need if the calls can't be de-escalated by our crisis counselors that take the call? We want to reduce the healthcare spending by the unnecessary trips to the emergency department. And that also correlates to to reduce use of law enforcement and emergency medical services. Because for years it has been, if someone's not familiar or knows how to access assistance for mental health, then they call 911. And that's not always the best option. If somebody is not committing a crime or they're not having a medical emergency, they're just having a mental health crisis. So we want to make sure that we have the system in place for children, youth, and our adults to be able to have these services. And that's where 988 is what we're working towards, is to continue to make it an effective system. But we also want to make sure that we're meeting the growing need for it at scale while providing accessible and equitable services. So we're identifying our high-risk populations, which you can see on here, and making sure that we're having the cultural responsiveness and we're providing the training and support to all of our centers that are taking the calls and helping them identify how to respond, as well as the resources available that's in the least restrictive environment and most efficient way of providing services. Next slide, please. So this just kind of shows you a trend of how our call volume has evolved over time. Pre-launch of 988 in July, you can see we averaged just under 2,000 calls a month. But once 988 launched, we have seen a steady increase in our call volume, which was predicted prior to going live with that. So we've been working with the centers to build capacity to make sure that Kentuckians in crisis are able to talk to someone in Kentucky who understands the cultural, the geographic, and just the general dynamic difference of Kentucky as it is. So since we went live with 988, we've been seeing about a 500 call increase each month, and we're expecting that to continue. And we haven't at this point done a huge marketing push on it because we want to make sure that we have the capacity to answer that. Because if a call is not answered at the primary center, then it will roll over to the backup center for Kentucky. And generally that's where it's answered. So we're doing that at about a 76% answer rate at the moment. But if it's not available to be answered by the primary or the backup in Kentucky, it does roll to one of the national backup centers. So there's always that the opportunity for a trained crisis counselor to assist someone and help them through that crisis. Next slide, please. Where we saw the significant increases in the chat and text once 988 went live. And you can see, particularly with the text component, when 988 launched in July, it became where you could text to 988 as opposed to a 5-digit number. So we know that the majority of those using text are our youth, and they tend to do it in the evening. So we currently have one center that is taking chat and text for Kentucky on a Monday through Friday basis for 3 hours at a time. And again, this is something we're working to build capacity so that someone in Kentucky experiencing a crisis that needs to chat or text with someone can do that with someone from Kentucky. And we're continuing to evolve that, but focusing on the primary thing and making sure that the calls are being answered, since that's where the greatest demand occurs. Next slide, please. So you've probably seen this if you've heard anything about 988, is that it is considered one of the most significant behavioral health policy efforts since the Medicaid expansion in 2014. And I say that and I reiterate that because it is something that we're working to evolve. It is not where we stop now that we have someone to answer the call. Now we're building on the other pieces that go with it. So next slide, please. So we're trying to get to the point where when you have a situation where you have a medical emergency or you need police or fire, you call 911. It's taken many, many years to get to that point from when 911 started. So we're trying to build the framework and the understanding that if you're experiencing that mental health crisis, that you can call 988 for yourself or someone that you care about. And the importance of this is, and the next slide, please, is that we want to get away from having law enforcement and EMS respond on every behavioral health crisis. And I use the example when I'm talking to law enforcement is that you have a child who has a behavioral health disorder or an emotional disorder, and they're just having a bad day and they're not wanting to go to school, but the parents are exasperated and they don't know what to do. So they call 911. Well, then that's going to traumatize the child by having law enforcement show up because it's not a law enforcement issue. So we want to get away from this unnecessary cycle of someone experiencing a behavioral health crisis, and then they're either transported to the emergency department or they are taken to jail. and then released without the support that they need to make sure that they are able to effectively manage that crisis. So this is kind of the state of what we're in now, is that perpetual cycle of 911's called, law enforcement or EMS, emergency department, jail, and release with no resources or support. So if we go to the next slide, you'll see what we're trying to work towards. And that is working towards the continuum of care, where we have the connection between our PSAPs, and we have the information that we need to share and do those things. So we're building mobile crisis in. We're working with the centers to have the information for the community supports and resources, and to build that into where there's follow-up, where there's support, and there's continued involvement with that, so that we're able to mitigate the impact on our emergency services, both for law enforcement and the emergency department, while providing assistance and support in the least restrictive environment, meaning we go to where the person is at that point through mobile crisis. So next slide. So that is it in a nutshell. There is so many other things that I could actually tell you about. There's so many pieces to it, between the websites and the bed registries and all the things that we're working on to support all of our Kentuckians, from our youngest to our oldest. And one thing I will end on is that we're seeing a huge increase in contact from young people, 8, 10, 12-year-olds that are experiencing crises. So we know that the system is working, and we're wanting to continue to do it and continue to build it to where we can support any Kentuckian experiencing a crisis. So thank you for the opportunity. And I know that was quick. I'd be happy to come back another time and talk more 988, or I'm happy to talk to anybody at any time. So thank you all.
Angela is a great resource for all of us who are interacting with patients and others who are in need. I will ask a real quick follow-up from Kathy. Angela, how does 988 differ from Smart 911? Is one of the questions in the chat.
I'm thinking Smart 911 is like that next gen 911 where they know location and that. So 988 at this point, to allow for voice and choice, and the anonymity, does not do any type of geolocation or geo routing. What we are doing on the federal level, and I say we because it's the 988 piece, they're looking at geo routing, meaning that they could pinpoint a general area for someone as opposed to a specific location. So they haven't gotten to that point yet, because it is about contact choice and giving them the voice to maintain that confidentiality. So there's more to come on that.
All right, good. Thank you so much.
If I could piggyback on that real quick, I think Smart 911 too is giving them its safety planning for the future. So it's like you have a loved one that has Alzheimer's, or a child with some type of medical health issue, that they have that in the background. And so that's wonderful. And that's a different type of safety planning, where, like Angela says, 988 is in the moment crisis and can be anonymous.
Thank you, Darcy.
Okay. Thank you so much. Well, we're going to, in the interest of time, we're going to transition over to our panel questions. We're going to add in Jennifer Willis as kind of a respondent to this great information that's been presented. Jennifer is interim CEO with Pathways, located in Ashland, Kentucky, and she was previously chief clinical officer there. So Jennifer comes with a wealth of clinical experience into our discussion. And I wonder, Jennifer, if kind of just as you think about the presenters today and what they've presented, what comes to your mind as some of the top tips and highlights that you'd like to make sure that primary care providers and health systems think about related to mental health crises? And again, thank you for being with us today.
Sure. Thank you for having me. I think probably the most important piece is just always understanding and knowing who your community mental health center is. We are the safety net providers for your communities. Pathways, which is where I'm the CEO, covers a 10-county region, as well as, as Darcy mentioned, New Vista has 17 counties, but it's just very important to know who your community mental health center is, because we are the safety net. We are the ones that all of us provide 24-hour mobile crisis services. All of our outpatient offices have walk-in services for any type of crisis. Specifically, Pathways has, as well as our mobile crisis teams, we also have a co-responder team in Two of our counties now. We've just expanded to a second county, which is really kind of neat as well, where Pathways can go out with law enforcement if you have a patient who's having a mental health crisis, in their home or in your office, or really anywhere that's a safe location. But I definitely feel like the most important piece is just knowing who to call, who to contact. I think the second thing, and I've just experienced this myself with my mom, that's pretty important for primary care providers, is that when your folks are asking any provider, but specifically primary care folks, when they're asking those PHQ-9 questions, that everybody asks, what I quickly discover is people will ask someone, are you feeling depressed? And their response is generally, well, no. And when I was in an appointment with my mom recently, she was like, oh, no, not at all. And I looked at her and I thought, that is the least accurate comment I've ever heard. And she said, well, I don't sit around crying all the time. And I thought, wow, okay. So here's someone that's clearly knows a lot about mental health just from being my mother, but still didn't understand that you could be depressed and not sit around crying all day. So I think that's another thing that we can all do better, is really talking about what are symptoms of depression, anxiety, thoughts of suicide. And I know that's very scary for people to ask someone about suicide, because you're afraid to go there a little bit. But if I just think the more detail oriented you can be when you're asking those questions, like just the basic things, like, have you lost interest in something that you used to enjoy? Do you have a hard time getting out of bed? Are you having a hard time sleeping? Just making it more than just those quick questions. And I understand that, everybody has a lot to do and you have a lot of ground to cover, but I definitely think that's very important. And it was just a reminder to me last week when I was at the doctor with my mom that, wow, we really need to do better with that as a whole. And I'm sure, our staff do similar things where we don't go into the detail that we need to.
Right. It's constant kind of reminder to be intentional with the patient, make eye contact to really, elicit the best response. So I'm going to ask you first, Jennifer, this question, but I also want to open it up to the other members of the panel as well to talk about. But, one of the things that we know we've seen is that it is so stressful on staff when they have someone who is in the office who screens, first for those questions that they're set and that they actually are considering suicide. And then, they're having to respond in the moment to this, and there's a crisis and they want to get them help. And, a lot of times people will look back and say like, oh, I didn't handle that the right way. And there's the sense of moral distress of just having to work through that. Did they do the right thing for the patient? So I wonder if you can talk through for our folks who are part of, you have to deal with this every day. More our primary care teams are dealing with it a little bit more intermittently. How do you help your staff to deal with crises like that and to work through some of that distress they might feel over how they handled a crisis?
Sure. Well, mental health crises are definitely just as endorphin inducing as physical health crisis or a code or anything else. And, I'm a nurse by trade, so I certainly get all that. But I think the most important piece is to make sure that you have a de-escalation time for that staff, to really allow them to talk a little bit about how they feel, give them time to, take a walk, have a drink, a soda. I shouldn't say it like that. Just be able to take some time to just process it and relax a little bit, because it is very anxiety producing, even for the staff. And I mean, at our centers, especially our crisis units, like we have a calm room for our staff. And there's, like a nice comfortable chair, there's soothing music, there's drinks in the fridge if you need a water or soda. And there's just some things to really help the staff member de-escalate, kind of calm down and regather themselves before they move on to the next crisis. And that's been something that we brought on. We started doing this about 5 years ago. And we've had a great response with having kind of that calm room. You know, it smells good. It's just very calm, and it kind of speaks to all the senses. But I do think it's just important to allow that staff the time to de-escalate and kind of share their feelings and then just be supportive of them.
Wonder if our other speakers want to chime in at all and offer any other thoughts.
I was just going to share that when your patient is having a behavioral health crisis, I think it's different than a medical crisis because, you know, I think like emergency room dramas, right? If someone's having a heart attack, it's go, 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 go. But if someone expresses that they're having suicidal thoughts, or you're recognizing, I think there's some psychosis, they're off their meds with schizophrenia, it's almost kind of slowing it down, and you're probably going to have to take a little bit more time. And it's taking a deep breath, being okay with tagging out. You know, I've been doing this a really long time. And even after so many years, there are times I'm like, I need some supports. I need someone else to come in. This is overwhelming, or I need to consult, you know, having more brains on it. And it could be like, maybe you're in the middle of it, or because when it's a crisis, right? It rains, or when it rains, it pours, feast or famine. So maybe calling your community mental health center. Every community mental health center has an 800 number, or calling 988 because they are answered locally saying, listen, here's what's going on. We need some assistance. What are some resources? And that could be your collaboration too. But sometimes they take a little bit longer, and that's okay.
Good to note. Any other comments or thoughts?
Trudy, the only other thing I was going to say is I think it's important to remember to be willing to ask the questions. I think a lot of times we try to avoid because I don't know what I'm going to do with the information. It's okay to not know what you're going to do with the information, but it's also really important that you ask those difficult questions and then figure it out in the moment. Like Darcy said, use your resources, but don't be afraid to sit with someone and allow them that space to talk about what they're going through. To the extent that you sort of convey to them that they need to box it up and keep it there and figure it out, they're not going to be open. But we can go a long way in our system by just saying, I can tell something's going on. Help me understand what's going on with you. Tell me where you're at.
Great. That's great. Well, this has been a wonderful session. A lot of great information shared. Thank you so much to all of our speakers today. Appreciate it so much. Lindsay, Darcy, Angela, Jennifer, your expertise is really invaluable. And hopefully for those of you who've been participating today, this isn't the end of the conversation, because our hope is that after this session we will have a rich set of resources available to you, the recordings, the slides, as well as links to safety plans and other resources that were talked about today are going to be made available on our Behavioral Health Community of Practice website. And please do share those. If you have other information to share from your organization that you think would be valuable for others to know about, let's share it. This really, the spirit of this is really collaboration and learning from one another so that we can do the very best for our patients. I want to go on to the, just real quickly, as we're wrapping up today, and say the mental health first aid training. We've talked about, you know, again, how do you develop the skills to do the active listening that Darcy talked about and that Lindsay mentioned. Really, the mental health first aid classes are wonderful training for providers, for administrators, for rooming staff, for others in your organization to address mental illness and to respond in times of crisis, and to have that training. It's free to your staff. Go ahead and if you haven't registered for this, please do. And it's open really to everyone. So tell others about it as well. We want to make this available across the community for our healthcare provider partners. Also, too, we want these sessions to be as helpful as possible to you, and we need your feedback. So we always, after every session, we provide a link, and we love to have your comments. And again, this is also an opportunity to tell us something that you feel like is missing or that you'd like to know, and we will follow up with you on those things. So please do follow up on the Qualtrics survey to give us your feedback. Next month, we will have another Behavioral Health Community of Practice session, and we're going to focus on primary care and mental health cross-specialty collaboration. Have another great set of speakers. Please do register for that event as well coming up. And then if this is the first time you've joined us today, all of our previous sessions are available through our Behavioral Health Community of Practice website. We encourage you to go back. Really phenomenal resources available from those sessions. Really encourage you to go back. And I want to just finalize today by saying thank you to all of our presenters for doing a phenomenal job today. You're wonderful. I feel so encouraged that in Kentucky we have such caring, dedicated people really who are working in this space to be working on behalf of our patients. So thank you. And thank you also to our support team at the Kentucky Regional Extension Center and the Healthy Kentucky team here at UK for all they've done to make these sessions possible. We hope you have a wonderful day, and we thank you for being with us. Take care.
Thank you so much.